Good afternoon, everybody. I've got two large topics. I'll try to roll them in 7 minutes. Polypoidal vasculopathy, or PCV, and idiopathic juxtafoveal cholangioplasia. There are no financial disclosures to make. PCV, as described by Ciadella in the survey, is a coronal vascular network of vessels ending in aneurysm or polyp-like structures associated with multiple recurrent serosanguinous RDs and PDs. It was also known as the posterior uveal bleeding syndrome or multiple recurrent RDs in black women, and has been considered to be a benign subtype of AMD. There are differences in Western Asia in terms of the prevalence, 4 to 14% in the West and 9.3 up to 57 to 54% in Asia. Clinical profile also varies. In the West, largely seen importantly in the female population, tends to be bilateral peripapillary location and tends to happen earlier in life. Whereas in Asia, happens more in males, tends to be unilateral, more macular in location and tends to occur later in life. So this is a very nice erudite review which came through, published in Retina last year in April. And on behalf of the expert PCV panel, they put out these evidence-based guidelines, and since the time is premium here, I'll just be focusing on the recommendations of this group. Largely, this recommendations of this group was based on the Everest trial, and some of them will come through. So the clinical diagnosis, basically the cornerstone is serosanguinous maculopathy, and I'll be showing examples, and they should have one of these characteristic features: serous or serosanguinous or not PED, massive macular hemorrhage, presence of typical subretinal orange nodules, or a history of being an anti-VEGF non-responder. And in this event, ICGA is the goal set to identify PCV. So this is the typical cluster of orange aneurysmal polypoidal dilatation, choroidal vasculature, which is again macular or peripapillary, and it's associated with recurrent hemorrhages, could be subretinal, sub-RP, or vitreous. Subretinal fibrosis scarring is typically minimal compared to AMD, and tends to be associated with hypertension and retinal arterial macroaneurysms. Exudative and hemorrhagic PEDs are the most characteristic features seen up to 85% of cases in Ahuja studies and more than half of the cases in other studies. Serous PEDs and RDs are usually seen, but rarely PCV can also exist peripherally, can also coexist with true CNVM, and can also exist in one eye with a CNVM in the fellow eye. This was seen in 5.5% of 289 eyes from Maluka study. Investigations, ICG is the gold standard as I mentioned. What one needs to do is diagnose PCV. If you find single or multiple nodular, focal nodular areas emanating from the choroidal circulation within the first 6 minutes, that's important, first 6 minutes after injection of the ICG. And then you should look for one of these features: nodular appearance on stereoscopic view of the ICGA, hypofluorescent halo surrounding those focal hyperfluorescence, branch vascular networks or BVNs, pulsatile polyps, and focal hyperfluorescence corresponding to that orange nodule, also associated with massive submacular hemorrhage. Then one needs to treat if the PCV is active and symptomatic. Then there is no doubt you have to treat. But you can observe or you can treat if the patient, the PCV is active but asymptomatic. You have the option of observing. When is it active? It is active if you have any of these 5 attributes. If there is a drop in vision of at least 5 letters ETRs, the drop being attributable to PCV, and there is sub or intraretinal fluid, PED, subretinal hemorrhage, or FA agents of leakage. This is an example of case of PCV with FA and ICG alongside. You can see the polyps showing up better on the ICG, okay, and in the 4 to 5 minute phase, the polyps are still there on the ICG in the late phase. And you can see the classical bilobed PEDs. Another case where you can see the BVN in the early phase on the left and the right polyps showing up beautifully. And again you can see the polyps there, and subfoveally you can see the notched PED and the large PED subfoveally. Branched vascular networks in PCV are, as you can see here on the right, an integrated network of dilated tortuous choroidal vessels, which is not an absolute requirement for diagnosis and typically is not there in small lesions. Treatment guidelines is again proposed by the group. For extrafoveal PCV, vasomotor coagulation can be done. In our experience, transpupillary thermotherapy also does well if it's titrated. For subfoveal and juxtafoveal PCV, standalone PDT, ICG guided, or in combination with 3 monthly injections of Lucentis or ranibizumab 0.5 milligrams. Otherwise, ranibizumab monotherapy can be done if PDT is contraindicated or it's not possible. Combination is the treatment of choice if there is leakage from these BVN polyps, or if it's also the large amount of subretinal fluid or exudation, and if there is ICG features which make PCV and CNV diagnosis ambiguous, or there is a combination of both. In such cases, you can do combination. How do we monitor these patients? FA, ICGA, OCT is performed 3 months after treatment initiation, and then monthly examination with a thorough clinical examination. If there is incomplete regression of polyps as assessed on ICG at 3 months, you could retreat with standalone PDT or combination therapy. But if there is complete regression as seen by ICG, but there is leakage on FA or there is some fluid on OCT, you could retreat with Lucentis monotherapy. So this is for the principles. I'll summarize this if I have time later. Again, IJT going on, GAS gave us these groups, but it was deemed that it was a little complicated. So Januzzi went ahead and simplified it with 2 types, type 1 inducible telangiectasia, type 2 perifocal, with non-proliferative and proliferative, which was essentially subretinal neovascular membranes. An example of type 1, laser photocoagulation is the mainstay, where moderate intensity grid pattern, titrate and targeted. Intravitreal pharmacotherapy with steroids or anti-VEGF can be done, but these are temporary. Radiation retinopathy because of microangio occlusion is a closed DD here. Type 2 MACTEL, this is a typical picture with the ooze, and you can see the pigments right there depending on the vessels. 5 stages. Stage 1, no clinically evident vascular abnormality. Fluorescein shows mild staining in the late phase, and there is a loss of central hypoautofluorescence. OCT shows thinning of the outer nuclear layer, seen temporally, as you can see here, autofluorescence and the OCT with thinning. Stage 2, there is a mild loss of retinal transparency. There is no clinically evident telangiectatic vessels. DD here is bullseye maculopathy, CSER, headoid macular degeneration, Stargardt's cone distribution, lamella macular holes, AMD, and crystalline retinopathy. Stage 3, you have prominent right angle retinal venues, as you can see here. Stage 4 has RP, hyperplastic plaques, because of the stimulation of RP by the extension of the deep back retinal vascular proliferation, looks like old focal scars. And this is an OCT picture which shows you this scars. Subretinal neovascularization in stage 5, which is a dreaded complication and a visual debilitating complication here. Example here, you can see the leakage from the SRNBM and the OCT picture. Another example with the PD. And fundus autofluorescence is now, the earliest is now a new diagnostic standard, as you can see very early change from FAF. Systemic associations of IGT tends to be associated with diabetes mellitus, impaired glucose tolerance, hypertension, dyslipidemia. Cause of visual impairment, pigment clumping at the fovea, photoreceptor loss, foveal atrophy, subretinal neovascular membranes, subfoveal debris which can occur, macular holes can occur very rarely. Treatment for non-proliferative, there's no proven treatment. Proliferative, mainly intravitreal VEGF. Earlier it used to be PDT and TTT. As shown by Narayan et al., early therapy is effective in visual improvement, and ranibizumab was included to bevacizumab in their study. MACTEL project, which is on and put out a lot of studies, as a natural history observation study, genetic studies, helps create awareness amongst clinicians and patients. So in summary, pre-diabetes is a common association. Non-proliferative MACTEL is not treatable. Early diagnosis and treatment of proliferative MACTEL improves visual outcome. Structure function correlation aids prognostication, and multimodal imaging may further enhance understanding of pathogenesis. Thank you.
Thank you. Very rapid.